Hi, everybody. Welcome and to our final in our series of installments this month, which is Gynecologic Cancer Awareness Month here at the Kelly Gynecologic Oncology Service at Johns Hopkins. And tonight our topic is what we've labeled From Whispers to Shouts, advocating for awareness, prevention, and early detection. And we are very lucky because like many of the sessions this month, I've gotten to choose some of my favorite people to have join us. So two of my partners are here tonight to talk to us about these topics. We have Dr. Kimberly Levinson and Dr. Anna Bevis. And so they introduced themselves in our very first session, but this month has been very long, actually. We were sort of reflecting on this today, that there's been a lot going on and then it's felt very long. It is actually a long month. So there have been 5 weeks and not just 4 to make all of us feel better. But since it has been a long numeric number of days since they first introduced themselves, we will let each of them introduce themselves again this evening. And only because she's the top left and I always start with the top left on my screen, which does not correlate to everybody else's. Dr. Levinson, why don't you go first?
Sure. Hi, good evening, everybody. I'm Kimberly Levinson. I'm one of the gynecologic oncologists with KGOS, and I primarily work out at our GBMC sister site. I have a strong interest in cervical cancer prevention, and that's part of the thing that we're going to be talking tonight about, as well as just prevention of all gynecologic cancers as well, which we're going to be touching on as well. So we look forward to talking with everybody.
And Dr. Bevis?
Thank you, Dr. Worthington. Hi, everyone. I'm Anna Bevis. I'm one of the GYN oncologists primarily practicing out at the downtown location at Johns Hopkins. And very similar to Dr. Levinson, I do have a strong interest in cervical cancer and HPV-related cancers, and we actually work on quite a bit of research together on that. So the general theme of being able to prevent these cancers, I'm very excited to talk to everyone about today.
And not surprisingly, given their areas of expertise and sort of what we're going to focus on tonight, I think we're going to start with sort of a pressing question that lots of people ask and comes up in different contexts and different moments, which is, can we really prevent cancers? Like, is that possible? Is there anything I can do? So we'll obviously probably riff on this for a while, but for whoever wants to get started, can we prevent cancers?
Dr. Bevis, do you want to start?
Sure. Yeah, I think it's a loaded question. And I think that we are starting to find that for some cancers, the answer is yes. And we are, endeavoring in more research to try and make the answer yes for more cancers. So as we start to figure out what causes certain cancers, and I think a big kind of misconception that I see a lot of my patients have is that every cancer is the same. They say my friend had chemo for this other cancer, and they think that the cancer acts the same and the chemo is the same, and therefore the prevention, the recurrence is the same. But every cancer, even within GYN cancers, every cancer is very unique. So I think, can we prevent cancer? We have proven that we can prevent cervical cancer. And that is because we have a test, the Pap Smear and an HPV test that can pick it up early. So if you can get that type of test, called a screening test, for every cancer, then yes, we will be able to prevent them all. So for now, we have a couple of cancers that we can definitely prevent. And then I think educating everyone on the symptoms of cancers at least helps in us detecting it earlier where we don't have tests yet.
Yeah, and to kind of come off of that, the other thing about cervical cancer that's so important is obviously that, as we mentioned, there is a vaccine now for cervical cancer as well. And cervical cancer, I think, is an interesting one to talk about in this regard, particularly with prevention, because of the fact that we have what's called primary prevention, which means that we can prevent this before it ever develops, before you ever get the cause of cervical cancer, which is HPV, the human papillomavirus. So the vaccine that we currently have is to prevent the acquisition of that virus, which then leads to not getting cervical cancer. But then we also have secondary prevention, which is the screening test, which does allow us to pick up precancers. For some of our other cancers, as Dr. Bevis was saying, the early symptomatology is really key. For example, endometrial cancer, many times we're able to pick up endometrial cancers early because of bleeding. And so when women know that that is something that they should present to their gynecologist for, then a biopsy can be performed in a timely manner, and we often are able to pick up that cancer early. But unfortunately, there are several cancers, not only gynecologic cancers, but ovarian cancer being one, where unfortunately we don't have good preventive mechanisms, either primary prevention or screening studies that help us to pick up ovarian cancer early. And unfortunately, the symptomatology is quite vague and often doesn't lead to early detection either.
I think that I 100% agree with that. I think that with endometrial and uterine cancer, we're hoping at some point there will be some kind of screening test, especially for ovarian cancer, because most people are diagnosed at a late stage. But there are some things that you can do when you're throughout your lifetime that can help prevent your risk or lower your risk. So for endometrial cancer, we know that it's driven by the hormone estrogen. And estrogen levels go up when you have more fat. So people who are heavier with more fat on their body will actually have a higher risk of endometrial cancer. And so staying healthy at a healthy weight and exercising can prevent it. And then similarly, because we know it's driven by that hormone estrogen, the hormone progesterone can act against the effect of estrogen. So things like birth control pills, the IUD that has hormones in it, the patch, the ring, all of those birth control methods actually lower your risk significantly of developing uterine cancer and are also associated with a lower risk of ovary cancer. So there are some things that, even though we don't know yet how to pick these up early with a screening test, there are some things that women can do at a younger age to help prevent them later on.
I think we've often, all of us have probably had the experience of having somebody come into our office and say, I'm done having kids. I just want all my GYN parts out. So just take them out so that the risk is gone. Because if they're gone, the risk will be gone. And I'm asking that question, or posing that question clearly in the context of somebody, the implication has no reason to have that surgery done. But are there ever patients where you say to them, oh, wait, actually, in addition to the risk reduction strategies that Dr. Beavis mentioned of OCPs or hormonal methods of risk reduction, or exercise and weight control methods of risk reduction, or Dr. Levinson mentioned, I think it was Dr. Levinson, the vaccine for the HPV vaccine. So those are all risk reducing methods. Do we ever actually tell patients they should have organs out to risk reduce?
Yes, we absolutely do. So this gets to the question of when we know, for some patients, we know what the cause of cancer is, and sometimes there are genetic reasons why patients might be highly susceptible to cancers. And this is particularly true for ovarian cancers and for some uterine cancers, that we know that there's an association with some of the genetic mutations, most commonly with what we call the BRCA genes. There are other genes as well that are associated with elevated risk of ovarian cancers. And then with endometrial cancers, with something called Lynch syndrome, which also puts out patients at elevated risk for both uterine and ovarian cancers. And so for these patients, because we know that there is an elevated risk, prophylactic surgery certainly is standard of care. And once patients have completed their childbearing, this is recommended. And we have a lot of information now about the ages that patients acquired tend to get these cancers, and that helps us to guide patients and help them to determine when is the best timing for them to undergo a prophylactic surgery, and weigh the risks and benefits of doing that in a timely fashion for them. So I think that that's a really important thing, because it's one of the things that I, as a gynecologic oncologist, take pride in the most, because one of the best things that we can do is prevent cancers. And if we can identify patients who have this genetic mutation and remove, the tubes and ovaries and at times the uterus as well before cancers ever develop, then certainly that's a lot better in many circumstances than treating what many times becomes an advanced cancer.
And then to add on to that, in women who don't have any of those mutations, but are done with having children and they would like to have some form of sterilization, which, we all call tying your tubes. What that's previously meant is removing a piece of the tube, the fallopian tube, to prevent pregnancy. And we now know that more than half, if not most, ovary cancers probably start in the fallopian tube. And so we are routinely, when we're doing sterilization procedures or when our OBGYN colleagues are doing these procedures, tying the tubes, they're actually removing the entire fallopian tube. And we do that at the time of hysterectomy, as well as when someone is done childbearing. And we don't have decades of data following up on that yet, but there's pretty good data to suggest that's going to lower the risk of ovary cancer even more than just that classic tubal tying your tubes, which was previously just removing a segment. We do expect that removing that whole fallopian tube is going to significantly lower someone's risk of ovary cancer in the future.
You sort of mentioned when you were talking, Dr. Levinson, symptoms. And you mentioned endometrial cancer showing symptoms early, and then sort of lack of good symptoms for other cancers. So if we were to kind of tick off each of our GYN cancers, and we start with endometrial cancer, because it's the most common of the GYN cancers. So if we start with endometrial cancer, if a patient said to you, what's the most common symptom of endometrial cancer? What would you say?
Yeah, so certainly, bleeding, postmenopausal bleeding is the most common symptom that most patients present with. And I think, this gets back to the point of, we do have certain tools, whether they be vaccination, screening, or symptoms that that can really help us to not only prevent cancers, but save women's lives, right? So if we can catch cancers early, then we can do that. And I think one of the biggest things that we face is that many people don't know to present with these symptoms. So I think it's a really important factor to bring up and talk about, because I certainly have had many patients who come to me and say, gosh, I didn't know that I wasn't supposed to be bleeding at this age. And I've been bleeding for longer than, probably I should have at this point. And it's something that they could have presented earlier to us, but didn't know. And so didn't get to us until a later time frame. So I do think that even though some of the symptoms are vague for many of our cancers, and I know we'll go through the cancers and tick them off, but for endometrial cancer in particular, certainly bleeding is one that's more objective and definitive and can say, oh gosh, I know I'm postmenopausal and my periods are done and I shouldn't be bleeding. And that certainly is something that any postmenopausal bleeding should lead to a presentation to a gynecologist for further workup. And so that is really a number one for endometrial cancer.
Yeah. And I think too, what you said about presenting then to the gynecologist, because I think the follow-on question that patients often ask is, okay, I have these symptoms, who do I go to with this symptom? And I think some of our cancers, there's maybe more than one person, but certainly for endometrial, to your point, and to emphasize a little bit that idea that it's the gynecologist in this situation that is the best next stop, as opposed to our second most common GYN cancer here in the United States, which is ovary cancer, where I'd say that answer to who to go to may be more vague, just like the symptoms are more vague. So Dr. Beavis, if someone says to you, like, what are the symptoms I should worry about for ovary cancer? And if I have those symptoms, who do I go to? Where do I start? How would you frame that, and how would you explain that sort of starting point?
So I will say, I think that's a much tougher question than endometrial cancer. And I think that's what we've been struggling with trying to help women detect these cancers earlier. So the way that I describe the symptoms of ovary cancer is essentially anything that makes your tummy feel funny. So you could have bloating, you could have diarrhea, constipation, you could go back and forth between those two, you could have any kind of belly pain, discomfort, something just doesn't feel right, it's usually a very vague symptom. And then some other ones that are slightly less vague, if someone's feeling full really quickly after they eat, and if they're losing a lot of weight, having night sweats, that's more concerning. But I think that especially for a lot of those vague symptoms, I always say, well, if someone told me I needed to tell a doctor every time I had those symptoms, I'd probably be calling a doctor every day. So my rule, it's general rule, but in general, if you're having a symptom for more than 2, or if it really feels very different to you than how it normally feels, it's okay if it's a day, that's fine. But if it's lasting longer, and I have this general rule of 2 weeks, then it's lasted long enough and it's time to go and see a doctor. Now, because the symptoms could be anything from something in your intestines, to your ovaries, to your uterus, to your bladder, I usually recommend going to your primary care doctor first. But I also think it's really important for women to advocate for themselves at their primary care doctor. And so if they feel like it's something in their pelvis or their lower abdomen or anywhere in their abdomen, and whatever the initial test is doesn't show anything, if they're still having symptoms, then I do advocate that they push their doctor to send them to a gynecologist. And I think that often our patients end up going to see someone about intestinal issues. They'll end up with a gastroenterologist before they end up in our clinic, in the oncology clinic. And I think that when you have such vague symptoms that could be a bunch of different things going on, the primary care doctor is a great place to start because they can think of all the different things it could be. But then usually you're going to probably need to see more than one specialist to try and figure out what's going on.
And I would just add to that, I think that that's exactly right. And I think, there's 2 other things that I would add, which is one, that I think it is really important as a patient to be your own advocate, as Dr. Beavis was saying. If you feel that something's wrong, then even if somebody's not able to identify what that is, certainly looking further is really important, because unfortunately, many of the times, these symptoms are vague and it's hard to identify what exactly is going on. And unless a patient really is able to be their own advocate, sometimes that can delay further workup and further care. The other thing I think that's important to recognize is that, unfortunately, many of the symptoms that we're talking about don't occur until later on or later stages of the disease. And many patients will ask all the time, how could that be? How could there be all of this in my belly and I didn't know about it? And I think that it's important to recognize that things really do hide in the abdomen, and particularly with ovaries. Fortunately or unfortunately, ovaries tend to not produce symptoms and or pain or any of those things that we classically might think of that a mass might produce. And so, unfortunately, many of these symptoms that we're talking about really won't present until there is spread of disease in other areas. And that is why, we are so committed to trying to find further testing beyond symptomatology that would help us to identify these cancers earlier. Because unfortunately, if we wait for these symptoms to arise, many times they will be more advanced in stage when we're able to diagnose the cancer. And so most importantly, it's not something that patients should blame themselves for, feel like, gosh, how didn't I know? Because I think many patients may feel that way, and it's just not the case. Unfortunately, our bodies don't tell us that. And that's why we are so adamantly searching for something that can identify an early screening test.
That's right. So in terms of screening tests, probably the one that the symptoms are the least common presenting sign of is cervical cancer. But when patients do present with symptoms of cervical cancer, what do those symptoms often look like? Dr. Levinson, you want to start that one off? We'll go back and forth.
Yeah, sure. So that's exactly right. So unfortunately, cervical cancer also does not have early symptoms that often present, but fortunately, we do have screening that can lead us to the detection of early cancers in the cervix, or even precancers in the cervix, which is more ideal. When cancers do have symptoms in when cervical cancers do have symptoms, it may be something as simple as bleeding after intercourse. Sometimes if the cancer is more advanced, there may be some lymph nodes kind of in the groin area that may become enlarged. And that can cause some further symptoms, either swelling of the legs or those kinds of things. But many times, again, that's those symptoms present with more advanced stages of disease. And so realistically, the most important thing I think for cervical cancer prevention is, one, get the vaccine, and two, to make sure that you're getting appropriately screened and that you're following your physician's recommendations for screening to make sure that you're up to date on that screening so that any precancerous cells can be picked up.
I think that's such a good point, because I think nowadays people think, oh, I got the vaccine, so since I'm vaccinated, I don't have to worry about it, so I don't need my Pap smears. But it's sort of the combination of the two that really leads to that holy grail of prevention, so to speak. And we've mentioned it a couple of times, screening for cervical cancer, and we've mentioned HPV, and we've mentioned cells. So when we talk about the process of screening for cervical cancer, it actually can get quite complex. So let's, and actually this question just sort of came to me as we were talking, so I haven't even really thought out my phraseology of my question, but I think sort of what I'm getting at is, let's walk through, what does it mean to screen somebody for cervical cancer? What's the first step? What does that screening then lead to in terms of how do we evaluate whether our screening accurately identified? Kind of what's our process, and what is the actual screening test for cervical cancer? What is it actually looking for? Dr. Beavis, you're up next, or Dr. Levinson?
My turn. So if you'd asked me 15 years ago, I'd have a much shorter answer, but it's going to be a little bit more complicated because we've made some advances, and honestly, it's definitely to the bettering of our field and our ability to prevent this cancer. So what everyone probably knows about is the Pap smear, and what until about 10, 15 years ago was known as the annual exam. So you go to the doctor, and then depending on your age and your risk factors, but now it's at age 21 and above, you're going to have a speculum exam where an instrument's placed in the vagina to look at the cervix. And the cervix is essentially just the end of the uterus that shows, that kind of protrudes or kind of pushes into the very top of the vagina. And so when you put the speculum into the vagina, you can see the cervix. And that is actually a wonderful thing. It's not, nobody enjoys the exam, but it is wonderful that we're able to see the cervix. Unlike the ovaries, for example, we can actually see this organ without doing anything too invasive. And so a Pap smear is just taking a swab and basically collecting some cells. And what that means is just kind of scraping very gently on the cervix. And the cells that are there will then be looked at under the microscope. And that's what we classically think of as a Pap smear. And so if those cells look abnormal, then we'll move on to other things, which I'll talk about in just a second. Because the other thing that we now do, and it depends on your age, but in general, we also send an HPV test. So we can test for the virus. And if that HPV test is positive, depending on the exact type and on how your cells looked, then if it's concerning, then you may end up needing the next step, which would be what's called a colposcopy. And I think that's where you were going with this question, correct? Okay. So all the Pap smear or the HPV test does is send a signal that says you should look closer. So it doesn't diagnose really anything. It just says you need to look closer at the cervix. There could be something going on, could be precancer, could be cancer, could be nothing. So our next test is called a colposcopy. And it's the same procedure with the speculum so that we can see the cervix. And then the cervix is basically painted with what we call acetic acid, which is a very fancy word for vinegar. And that will highlight any abnormal cells when we look at it with a microscope. And we have a special microscope called a colposcope that allows us to look down the speculum at the cervix in a magnified view. So we can get a really good close look at the cervix. And then if anything looks abnormal, then you would do a biopsy. And so the screening test is to kind of say, should we be concerned or not? And the biopsy tells you, is there something there? Is there precancer, cancer or nothing. You don't really get that answer until you have a biopsy. And then once you have that biopsy from the colposcopy, you may need additional procedures to remove a larger piece of the cervix to look closer, or you may, in most cases, be able to go back to just following with Pap smears and HPV tests.
Yeah. So I think there are a lot of different tests to kind of talk about, and I think it can become very confusing for patients. And I think, now the recommendations also vary, and it can be hard to figure out what you're supposed to have. So there's several different options in terms of screening right now, in terms of whether you get both the Pap smear test and the HPV test, whether you just get a Pap smear test, or whether you get an HPV test alone. And all of those actually are different options that gynecologists may suggest for a patient, depending on their age, their risk factors, and all of those things, which does make the screening a little bit complicated for patients to understand, and to understand also the follow-up, because the follow-up is also based on what those results that Dr. Beavis talked about are. And it may be anything from the colposcopy to follow up in a year, to follow up in 3 years, to follow up in 5 years. And so it becomes harder to follow kind of this pattern of what you should be doing in terms of your screening, and when you should be following up. And I think that is, something that you really do have to join with your gynecologist on, to make sure that you're working together and that you understand why they're making the recommendation that they're making. The other thing that I just wanted to bring up in this context that I think is important for people to understand is that once the HPV virus is acquired, and I usually describe the HPV virus kind of like the common cold of sexually transmitted diseases. So most people will get it and most people will clear it, but sometimes it hangs around, and you can kind of think about that like a pneumonia, right? So some people will get a common cold and get a pneumonia, most people won't. But if the HPV virus is acquired and it hangs around in these cells of the cervix, that's when it can cause these changes to the cervix, which we call dysplasia or precancer. But the thing that I think is most important for people to recognize is that once you have the HPV virus, even if you clear it, it doesn't necessarily go away for good. So you need to continue to be screened, because it can be that the HPV virus can cause dysplasias again. And I think many people come to the gynecologist having maybe a positive screening test, whether that be a Pap smear or an HPV test, and say, well, what do I need to do to get rid of this? And, I think it's important to realize that unfortunately, we can't get rid of it. We don't have a magic pill or a magic cure to get rid of HPV. What we have is screening, which helps us to determine if HPV is doing anything bad, if it's going to cause a cancer there. But we can't get rid of it. And so, there are several patients who may be in this cycle of they have an abnormal screen and then they come back for a biopsy, and then they have another abnormal screen and they have to keep coming back for biopsies. And understandably, that can be a very frustrating process. But I do think that it's very important to stress that that is our only way to make sure that those abnormal cells don't continue to progress and become a cancer. And so, as frustrating as that cycle can be, one, at least we have that, because it's way better for us to figure out that we have a precancer there and take care of that than to have to go on to treat a cancer there in the cervix.
Yeah, and just to add to that, that's why we're so excited about the HPV vaccine, because we know once you have it, we can't get rid of it. So if we can prevent you from ever having it, that is the ideal. And we know now that the most recent HPV vaccine will prevent 90% of cervical cancers, 90. And that is huge. We have the potential to eradicate cervical cancer in this country. And we've been particularly excited about that because HPV can be such a frustrating experience for many women, even if they never develop cervical cancer. All of those tests, the biopsies, going back and forth, sometimes for years and years, as Dr. Levinson described, it's very hard on someone's quality of life. And I was just going to add also, even if your Pap smear is due every 3 years or every 5 years, having an exam with a gynecologist every year is still recommended by the American College of OBGYNs. And, I will say to women, you don't just have a cervix, you have a vagina, you have a vulva, you have a uterus, ovaries, and tubes. And even if you've had a full hysterectomy with, you have no uterus, no cervix, no ovaries, no tubes, you still have gynecologic organs. And I would say 90 times out of 100, your internal medicine or primary care doctor is not doing a thorough vaginal and vulvar exam. And so going to your gynecologist every year is still really important. And if you go every year, you don't have to remember how often you need your Pap smear because your gynecologist will know.
There are so many pearls and so many questions I have after those 2 segments that I don't know where exactly to start. But I'm going to make us go back and then we're going to go forward. So just to go back briefly, because this is one of the set of questions that Dr. Beavis, you sort of brought up, because you mentioned organs that at no point during our conversation have we mentioned previously. And actually, for much of our month, they don't get much attention, even though they are gynecologic cancers. So you said, you still have a vulva, you still have a vagina. And so can you get cancer there?
Yes, yes, that's the short answer. So these are they're much less common cancers. And I think that's why they get less attention, especially vaginal cancer is incredibly rare. But they're both very, they're just like any cancer, they can be very hard to deal with. And you can imagine if someone needs a surgery or radiation in that particular area, it can be, it can definitely impact your quality of life. It can be disfiguring and very, while we love taking care of our patients, it's always a hard thing to, have to tell someone if you have to remove a large piece of their vulva or vagina. It's just, it's very hard. So I have vulvar cancer specifically. I think that we need to get the word out on symptoms for that. As we talked about, bleeding after menopause is never normal. So it can be due to low estrogen, sure, but it always requires someone to evaluate it, a gynecologist. So it might be a symptom of endometrial cancer, but it also could be a symptom of either vaginal or vulvar cancer. And then for vulvar cancer, and to be, just in case, I don't think that my husband knows these terms. So the vagina is the tube that's inside of you where the speculum goes. And the vulva is the skin on the outside, which also some people call the labia or the lips of the vagina or vulva. So just to be clear about what we're talking about. So the vulva is on the outside, and most often women present with some kind of itching, and then the itching doesn't go away. And so this is again where my 2-week rule comes in. So itching for a day or 2 that goes away in the vulva and the vagina is fine. You don't need to go and see your gynecologist. But if you're itching every day, then it's definitely worthwhile to go and see a gynecologist. And it could just be irritation from urine, it could be irritation from sweat, it could be a yeast infection, lots of things that it could be that aren't cancer. But what we often see as GYN oncologists or someone who's had itching for 6 months, 12 months, more than a year, and they've tried a treatment and it didn't go away and they just kind of lived with it. And that's when it's definitely time to come to your gynecologist, because even some types of cancer in the vulva, you may not see or feel anything. And most women can't see their whole vulva unless you get a mirror. And even then it's kind of tricky. So you really need to see a gynecologist for that, specifically itching. I feel like a lot of my patients had that symptom for quite a while and just didn't know to report it and to advocate for themselves about it.
Yeah, I think that it brings back kind of the other point that you were making about the importance of seeing a gynecologist, right? Because of that idea that you can't necessarily see that whole area. So it is important to have somebody who's looking at that area, at least once a year. And then the other thing I think in terms of knowledge is it's important to know that, so we've talked a lot about HPV as a cause for cervical cancer. But HPV can also cause cancers of the vulva and the vagina. Now, unlike cervical cancer, there are other causes for vulvar cancers as well. And, something called lichen sclerosis or thinning of the skin that may sometimes happen in older women. Can also cause or be associated with vulvar cancers as well. And so these are things that it's important to know because if you have, for example, HPV of the cervix, then it's important to recognize that that can also affect other areas in the lower genital tract or the vulva and the vagina. Also, it's important to know that, for example, genital warts are associated also with the HPV virus. And while this is a different type of HPV virus, something that we call low risk HPV or different strains of HPV that cause this, those low risk strains can often travel together with high risk strains. And so when you see these kinds of things or recognize that there may be either changes to the cervix or changes to the vulva that are reflective of, for example, genital warts, this kind of has to heighten the awareness that maybe there's something else going on too, and that certainly it's important to see your gynecologist and make sure that there's no changes to the vulva. The other one thing that I always tell patients is that anything on the vulva that's different or that seems to be abnormal to you should be biopsied. So it's very challenging, even for us who we've been trained for years and years and years to identify things on the vulva and exactly what they are just by the naked eye. And that's because many of these lesions can present in multiple different ways. They can look completely different from one another and represent exactly the same thing. And so I always tell my patients, any change to the vulva, anything that you see on the vulva that's new or different really should be biopsied because somebody's got to look under the microscope at it and make sure that it's not something bad going on.
So you mentioned the HPV vaccine and mentioned HPVs traveling together, and there was mention of a new HPV vaccine, and often people just think of it as one thing. And so is there more than one HPV vaccine, and what exactly is the HPV vaccine, and what of all these references that you've made to HPV are actually included in the vaccine?
So I can start. So right now in the United States, there's only one available HPV vaccine. So that has been the case, I think, since about 2016, if I'm remembering my dates correctly. So the HPV vaccine was first approved by the FDA in late 2006, and it was like December of 2006. So it started being given in 2007, and it only prevented against 4 types of HPV. And the manufacturers of the vaccine chose to pick the 2 most common HPV types. There are multiple different types of HPV that can either be precancerous or potential to cause cancer or not. So they picked 2 that they know cause the most cervical cancer, and those are type 16 and 18. And then they picked 2 that cause genital warts, type 6 and 11. So that first vaccine we knew was going to prevent about 70% of cervical cancers because it covered those 2 specific cancer-causing HPV types. And then the manufacturers went on to then develop and add other types of HPV protection. And now the HPV vaccine protects against 9 types of HPV, 7 of which cause cancer and 2 of which cause genital warts. So they kept the same 4 they had, and they added another 5 cancer-causing HPV types to prevent against. And it's important to know this vaccine is not live. There's no live HPV live HPV in the vaccine. You can't get the virus from the vaccine. And in fact, your immune system will have a stronger response to the vaccine than it will to the virus. And so that's why we say, even if you've had one type, two types, whatever it is, it's still worth getting the vaccine if you haven't been vaccinated within a certain age range and in discussion with your gynecologist. But even if you have a positive HPV test, the vaccine still definitely has the potential to protect you against other types and causes this stronger immune response as well. So right now in the United States, there's just the one type that covers the 9 types of HPV, which is there are 2 other available vaccines out in the world, but none of them cover those 9 types. So we are lucky that that is the one that we have here.
Is it safe? You mentioned your immune response, but is it a safe vaccine to get?
Yeah, so this is, I think this is a question that often comes up, and that, luckily it's a very easy answer. Yes, it is safe. There has been tremendous data looking at this vaccine that shows the safety and efficacy of this vaccine for years now. And, with essentially the lowest risk of side effects. Of course, the major side effect is you're going to feel it in your arm when you get it. But luckily, this has proven to be an extremely safe vaccine to get. And I think, this question tended to come up more years ago. And I think now with all of the data and literature that is out there surrounding the vaccine and how safe it is, that question has, I think, hopefully, been better understood, and that data is better understood. But yes, it is extremely safe. And I think, it brings up the question of, again, back to when should patients get this vaccine? And again, because you bring up safety in children and safety in adults, and who is it safe for? And essentially, the guidelines now are up to the age of 45 patients can get this vaccine. And that's not because it's only safe in patients up to the age of 45. It's because that's primarily the patients that it's been studied in and been shown to be, from a public health standpoint, most efficacious in terms of when patients are most exposed to the virus. But this vaccine has data and efficacy and safety for children as well. And so I think that that's a really important point to make, because that really is the ideal time for patients to be vaccinated. Because again, we want to initiate this vaccine before patients become exposed, because you cannot get rid of HPV once you have it. So it is efficacious because it can continue to cover for other strains, even if you've acquired one strain, as Dr. Beavis was saying. But the sooner that you can get this vaccine, then we are able to prevent, all 9 types that are covered with the vaccine. And that is what ultimately is going to lead to the eradication of cervical cancer.
Yeah, so, it is recommended before any sexual debut, or when you start having any kind of sexual activity. I think it's important for everyone to know that that doesn't mean what we call penetrative vaginal intercourse in the medical world. But essentially, any genital contact can allow the HPV virus to transmit, although not as easily as with penetrative intercourse. But certainly, I think that often, initially when this vaccine came out, we heard a lot of parents say, well, I don't think my child is sexually active. And that's actually great. That's exactly when they should get the vaccine. And so it's recommended between age 11 and 12 with those routine pediatric vaccines. And you can actually give it as young as 9 years. And it is completely safe in that huge age range from 9 to 45. It's entirely safe. And I wanted to add on to what Dr. Levinson said and just highlight that the FDA knew when this vaccine was approved that it would undergo extra scrutiny by the public. And so they actually have been watching it closer than they typically do any other drug or vaccine. They set up a whole program, and they have millions of people's data that tell us that it is just as safe as any other vaccine. So we hear, stories in the news. My favorite is a girl who said she got pregnant from the vaccine. I can tell you that's not possible. And you'll hear these stories, but the data shows it's as safe as any other vaccine, and it's been studied even more than than those other vaccines. And it's been studied now for well over a decade. It must be going on 15 years now.
And the other thing that I wanted to say is that, I think the other question that comes up a lot is, well, who should be getting it? Should it just be women? And here, of course, we're talking about gynecologic cancers, but there are several reasons why this vaccine should be given both to boys and girls, ideally, or men and women. And, the number one reason, of course, is that, really this is a virus that is transmitted between and amongst both men and women. And it not only is important for preventing gynecologic cancers and getting to that herd immunity in terms of making sure that everyone can be vaccinated and that this virus doesn't persist, but also the other thing that I think many people don't necessarily know about is that HPV is a major cause of oropharyngeal cancers, or cancers of the head and neck as well. And so, this is a cancer that really is on the rise as well. And so particularly in men where oropharyngeal cancers are more common, this vaccine does prevent that as well. And so I think that that is important, again, public health knowledge to transmit and to know that this is not only a virus that causes cancers in women, it does cause cancers in men as well. And of course, penile cancers as well can be caused by HPV, although they're less common. But oropharyngeal cancers truly are on the rise at this time and are caused by HPV as well, which is prevented by the HPV vaccine as well.
So in line with that, we probably all have had the question of patients who have had cervical cancer ask us, should I get the vaccine now? Or somebody who is 41 and had severe cervical dysplasia and ended up in our office, or 38 or 36 or even 30 or 31. And so when patients who have had, there was a big focus in our language, and I do too, on prevention before, they're not sexually active yet. Oh, great, get them the vaccine now. But what about individuals who say, oh, I've had cervical dysplasia. Should I still get it? Is it worth getting it? Or I've been sexually active. Is it worth getting it? Should I get it? What do you advise? And particularly the cervical dysplasia and cervical cancer scenarios. Is there any data to tell us what to do in those situations?
I can answer that question, but Dr. Levinson's done more research on it, but I'm very familiar with what she's studied, and I can also tell you what I practice. I think that it's important to recognize that when vaccines and drugs are produced, they are tested and kind of approved by insurance for, do they help the population? Do they help everyone? They don't look at the individual necessarily. So in a patient who has cervical dysplasia, they have HPV-related precancer, whether or not they plan to have a surgery that will definitively manage that, such as a hysterectomy that removes the entire uterus and therefore the entire cervix, or if they're trying to retain the uterus in order to have children in the future for whatever other reason, the HPV vaccine can be helpful. In women who have cervical precancer and have a procedure called a LEAP or a cone, which is just a large biopsy of the cervix to remove those precancerous cells. Essentially, if you give the vaccine at that time, it may help prevent that precancer from coming back. So I definitely recommend it to all of those patients. And then in someone who's had cervical cancer, partially because of the reasons that Dr. Levinson spoke about, there are other cancers that HPV can cause. So even if you no longer have a cervix, we have the vulva, the vagina, the head and neck. And so I do recommend the HPV vaccine to those patients as well. And oftentimes we have to check to see how much the insurance will pay, and then have, a conversation about the risk-benefit ratio, because we're not, this is not the vaccine being given to prevent it in adolescence. It's later on, but I think it's a conversation worth having, because I think this HPV vaccine is a really important tool in our toolbox of preventing cancer.
Yeah, I completely agree with that. I think that the most data that we have is in the preventive setting. And so that's, and that's where this vaccine that's how the vaccine was made and how it has been studied primarily. However, as Dr. Beavis said, in the setting of having a cervical dysplasia and undergoing a surgery to remove those abnormal cells, we know that getting the HPV vaccine at that time does seem to decrease the risk of a recurrence there. There's a lot that we don't know what it can do. And in terms of, obviously we know if you have a certain strain of HPV, it can prevent the other strains. We know it can prevent, potentially recurrent dysplasias. But, in terms of what we call the immune response and what Dr. Beavis started to talk about before as well, we don't know a lot about what the effect of that immune response is on current HPV disease or current HPV related dysplasia. And so, I think the truth is that, there's very little downside to this vaccine, and there's potentially a lot of upside to it. Yes, from a public health perspective, that needs to be weighed against the cost of the vaccine and when patients are getting it and when their exposure is and all of that. But I think, I very strongly do recommend it to my patients who, one, are still sexually active and may acquire HPV types that they don't have currently, and two, that do have active disease because their body is actively trying to fight that. And if they have a procedure that removes the dysplasia, that we know that the recurrence risk is lower.
Super helpful. I want to shift a little bit and talk about what's coming. So when we think about strategies for prevention or strategies for risk reduction or strategies for screening, are there new things on the horizon that you've heard about or seen where you think to yourself that has promise? Like, I can't wait to see 10 years from now what that is able to help us achieve in terms of screening or early detection or prevention?
Yeah, I mean, I'll get started. I think one of the most exciting things about treating cancers and helping women with cancers right now in the current time frame is that we are in a time when, all of our knowledge about the genetics of cancers is really exploding. And what that means is, that we are understanding cancer much better and understanding what happens in the body when cancer develops and as cancer grows, which not only helps us necessarily in treatment, but which can help us understand how we can get to that crux of how do we prevent it. And so, one of the things that we at Hopkins are working on and that some investigators at Hopkins are very involved in is screening for both endometrial and ovarian cancers that focus on the genetics of the cancers and picking up some of the genetic changes that are happening that we may be able to identify much earlier than some of the symptoms that we've already talked about. And that to me is very exciting because we know that that's how these cancers are starting, and we're learning more and more about that. And if we can define a test that looks at some of these very early changes, I do think that is what ultimately will help us to identify these cancers earlier.
Yeah, I think there's definitely, I think the research that you're talking about includes detecting those genetic aberrations either from the Pap smear, so cells that fall from the ovary or the uterus down into the cervix and can be picked up on the Pap smear. So to be clear though, currently Pap smears are just testing for cervix cancer. They don't test for anything else, but there is the potential for them to do more. And then that can be coupled with a blood test. And there was recently a publication of a Hopkins study that looked at using, they call it a liquid biopsy. It's just a blood draw, and then looking for cancer genetic abnormalities in people's bloodstream, and then going to look for the cancers in women who have no symptoms, women and men. I think that we are probably years to decades away from that really being something that is going to help us prevent cancer, but I think it's exciting that we're starting to see the signal for that coming. And I especially think in our BRCA patients who, before someone with a BRCA mutation has that surgery to reduce their risk, we're often monitoring the ovaries with ultrasounds and checking a tumor level called a CA125. We haven't proven yet that we're really helping by doing that monitoring, but there are some studies still ongoing to try and show that that is helpful. And I think potentially coupled with these, tests that look for genetic aberrations in your bloodstream, potentially that's going to help these women prevent their cancers before they develop and potentially keep their ovaries a little bit longer if we can pick it up early enough that that's safe to do.
I always find we get down to the end and I want more time, and I definitely want more time, and I always promise that I'll end on time. So I've got to sort of start wrapping us up. And I think to end both our session tonight and also to sort of end our month, I want to ask sort of a closing future looking question, but more about advocacy and talking about GYN cancers and raising awareness. And so if each of you could choose one message that all of our listeners would hear and they would convey to all the women that they know, who would then pass the message on to everybody that they know, so that never ending pass it forward, a model that would eventually reach innumerable women, what would your message be? If you could share one message, what would your message be?
I can go first. I think that my message is very similar to some things that both Dr. Levinson and I touched on. And I think that absolutely most important thing for women to be is their own advocate. And so when something doesn't feel right to you, it's okay to keep pushing. We are, unfortunately, as GYN oncologists, always on the side of that ends with, the patient did have something going on and the workup did reveal something, and that's why they are coming to our clinic. But I'm sure there are many times that isn't the case, but I think that it's really important that if you, it's like in the airport, if you see something, say something. If you feel something, advocate for yourself and talk to other women about it. And I think that women with cancer need to talk about their symptoms, how they felt, how they picked it up. They need to talk to their families about their family history. It's really all about communication. I think we don't talk enough about what women go through. Oftentimes women feel like they're the only one they know who's been through this. And that's partially why we have, all of our support groups in the Woman to Women program at the Kelly Gynecologic service, because you aren't the only person and you shouldn't feel alone. And I think that by helping women really feel empowered to advocate for themselves and also report their symptoms and talk to each other about these cancers that only women are experiencing, I think that's the most important thing for me.
Yeah, I completely agree. I think that, we are in a field and I think, the women's cancer that gets the most attention and that people talk about the most is breast cancer. Whereas many of these cancers really don't get the type of attention or understanding about, one, what needs to be done for them and how to make good progress in these cancers, but also two, to make sure that women understand what they should be going to their doctor for and some of the things that we talked about tonight. The other thing that I will say, just, and maybe is a little bit more specific, but, to me, this idea about the HPV vaccine is really an important one. And I think what I would say is people ask all the time, when are we going to have a magic pill to cure cancer, right? Everybody wants to find that little magic pill that, we're going to be able to do something to cure cancer. And what I would say is we have it for cervical cancer. We can prevent this cancer. All we need to do is get this vaccine given and pervasive throughout, the population to be able to prevent this cancer. And so I think if people can think about it that way, in terms of that we do actually have a cure for this cancer, it's in our back pockets and we just need to use it, that is something that we really need to spread the word about, because the only reason why young women are still coming in and dying from this cancer is because this vaccine is not pervasive enough.
Yeah, thank you. I think that is the perfect way to end this set of questions. And I think the piece that both of you have contributed tonight to what you said is a long series of questions and answers and comments on all the things. If we had a core set of things that we wish every woman knew, I think you both did a beautiful job of sort of exemplifying the knowledge that that we wish everybody had. So thank you very, very much for that. And that thank you extends not just to Drs. Levinson and Beavis, who were with us tonight, but also to everybody on the KGAS team, both the nurses and the physicians and the PAs who joined us in our first session, and to the participants who joined us throughout each of our sessions. As I flipped through my thank you list there a little too quickly. Every guest that we've had this month has done a wonderful job of explaining or bringing light to an important topic in GYN cancer care. And I think there's a lot in GYN cancer care and in GYN cancers and in women's health in general that isn't given voice, and it doesn't necessarily have an opportunity to be emphasized. And so I think one of the things that I'm very grateful for this month is that we've had a lot of speakers who did a very eloquent job of bringing voice to many of the issues that women face, and bringing voice to the importance of clinical trials and moving gynecologic cancer care forward, and bringing voice to the challenges of the spiritual and mental and emotional needs of patients going through this process. And then also bringing voice to what knowledge, if every woman had and if everyone went out and shared it, would really impact the prevention of these cancers and early detection of these cancers. And we extend a special thanks to our sponsor who enabled this programming to take place this month, which is AstraZeneca. And I also sort of want to emphasize a little bit, if you want to connect. So in the KGAS Gynecologic Cancer Survivorship Program, we sort of use the words education and connection quite frequently, and we view that as sort of one of our primary motivators and one of our primary goals, to connect with people, to connect people. So we spend a lot of time trying to connect our survivors to help support each other, to connect our caregivers, to have them help support each other, and then to connect all of our community with information, with education. And so we've spent some time putting together various educational platforms, and this webinar series this month has been a part of that. We normally have our annual or semi-annual conference, and since we could not have our conference this year, which would have been the year we have it, instead we have these webinar opportunities, which fortunately we're able to then make available to the public on an ongoing basis. And so certainly through our website and our YouTube channel and our Facebook group, we're adding those elements of, or we hope we are adding those elements of connection and education. And thus far this month, I've greatly enjoyed the webinars. I always get a lot out of them. And then on top of that, the feedback we've gotten is that they've been very helpful. And so we're going to continue them throughout the year and do one a month. And our next one is going to be on October 23rd at 12 noon. And our topic then will be finding your quality of life coach, the role of palliative medicine in cancer care. And so Dr. Tom Smith, one of our most beloved palliative medicine physicians here at Johns Hopkins, will be with us and sort of talking about the role of palliative medicine and where you might consider integrating it into your cancer treatment plan. And so that will be our next webinar on the 23rd at 12 noon. So we just want to say a very sincere thank you for joining us and for raising awareness for your commitment and dedication to the Kelly Gynecologic Oncology Service and our survivorship program, and to all of our survivors who benefit each and every day from the connection that our community has created. So have a good night, everybody.